therapy for relapse or refractory T-cell lymphoblastic lymphoma. Dr. Liu, the floor is yours.
I'm going to present a novel and a successful patient or donor-derived anti-CD7 CAR T-cell therapy for refractory or relapsed T-cell lymphoblastic lymphoma. CAR T-cell were prepared by Senlong Biotechnology Company, and the phase 1 clinical trial was conducted in Ludaopei Hospital in China. I have nothing to declare. TLBL is an aggressive hematological malignancy, often presenting with bulky mediastinal masses or diffuse extramedullary disease. TLBL differs in various aspects from T-cell ALL, aside from the differences in clinical presentations. Only few clinical case reports exist for CAR T-cell therapy for TLBL. Here we explore the efficacy and the safety of anti-CD7 CAR T-cell therapy for 8 refractory relapsed TLBL patients in a phase 1 clinical trial. This slide shows construct of anti-CD7 CARs. Basically, this is second generation of CAR T with a 4-1BB as a co-stimulated domain. In our preclinical study, we compared 3 methods for deriving anti-CD7 CAR T cells. One, we call the naturally selected anti-CD7 CAR cells, NS7 CAR, in which we transduce anti-CD7 CAR into bulk peripheral T lymphocytes and allow CAR T cells to merge in vitro after fratricide. 2, CD7 knockout CAR T cells, we call the KO7 CAR, derived by CRISPR-9 gene editing. 3, NEK7 CAR, in which anti-CD7 CAR cells were transduced from purified CD7 negative T cells. We also had an abstract presentation regarding detail about those structure. If anybody interested, you may look into that in this ASH meeting. In our preclinical study, we did a comparison of 3 manufacture methods for generating anti-CD7 CAR T cells. NS7 CAR had a lower fold expansion than KO7 CAR and NEK7 CAR in vitro. NS7 CAR had a rapid and dramatic phenotypical transition from CD7 positive CAR to CD7 negative CAR T cells within a week. CAR molecule expression in NS CAR up to 92.4% was significantly higher than KO7 CAR or NEK7 CAR. Both NS7 CAR and KO7 CAR showed a comparable cytotoxicity and released high level of gamma interferon and TNF-alpha, but NEK7 CAR to a lesser extent. Both NS7 CAR and KO7 CAR had a robust protection against leukemia progression with a marked reduction of leukemia cell burden in our animal mouse model. So both NS CAR or KO7 CAR could be used for clinical trial. However, the benefit of NS CAR is that without needing for additional gene editing. 8 TLBL patients were enrolled with a median follow-up time of 177 days. CAR T cell can be derived, manufactured from either patient or from the transplant donor with 100% successful rate. 1 single dose was infused to each patient with 3 dose level as options. Median transduction efficiency was 86.5%. Median age was 37, from 14 to 47. Median bone marrow blast before therapy was 8.89, as high as 87%. Median prior lines of therapy was 5. but up to 10 lines of prior therapy. 2 patients were relapsed after previous allotransplantation. 7 patients had extramedullary disease involvement. 1 patient did not because this patient had prior palliative mediastinal radiation therapy. However, at the time of enrollment, the bone marrow blast was up to 87%. 5 patients had a diffuse extramedullary disease. 2 patients had a localized but bulky mediastinal mass. 2 patients had TP53 mutation. On our day 28 evaluation, 5 out of 5 patients with bone marrow blasts were able to achieve MRD negative CR. 3 patients without the bone marrow involvement before CAR T therapy still able to maintain 0 blasts. 5 out of 7 patients with extramedullary disease able to achieve extramedullary disease complete CR. 4 patients were achieved on day 28. 1 patient were on day 51. 2 out of 7 patients with very bulky mediastinal masses. 1 patient even up to 8.6 centimeters, able to achieve extramedullary disease partial remission, and 1 patient were stable disease. Subsequently, 6 out of 6 CR patients underwent consolidative allotransplantation at a median time of 55.5 days. 4 patients still maintain the CR in both bone marrow and in extramedullary disease at a median follow-up time of 223 days. 1 patient died from transplant-related mortality after second allotransplantation. This patient were relapsed from previous allotransplantation before receive CAR T therapy. 1 patient able to remain CR on day 147, however, subsequently lost the follow-up. 1 patient with stable disease and 1 PR patient received the salvage allotransplantation and currently still remained CR. Regarding the safety, 7 out of 8 patients had a mild CRS with a grade less or equal than 2. Only 1 patient had a grade 3 CRS. Median onset of CRS was 1 day. The duration was 16 days. Only 1 patient had a grade 1 neurotoxicity. Cellular kinetics of CD7 CAR T, their peak and persistence was measured by either qPCR or by flow cytometry study. You can see the initial time of expansion somewhere around 4 days. The median peak expansion somewhere around 19 days. The median duration of the days up to the last follow-up was 50 days, but it can be seen as long as 120 days. Conclusion. CD7 CAR T cell derived either from the patient or the donor have a high initial efficacy and a good safety profile in refractory relapse TLBL patients. Initial high CR could be achieved both in bone marrow and in extramedullary disease in the majority of patients. Even among those who harbored with a high-risk feature or had a diffuse extramedullary lesions. Patients with bulky mediastinal masses may require more than 1 month's time to achieve remission. Long-term observation and more patients are needed to further evaluation the safety and the efficacy of anti-CD7 CAR. Thank you very much for your attention.
Thank you, Dr. Liu, for this great presentation. I'll start off by asking two quick questions. First of all, did you notice an increased rate of opportunistic infection, especially with a longer follow-up, particularly with fungal and viral infections? And the second question is, how was the mediastinal bulky disease assessed? Was it using CT scan or PET scan?
Okay, for first question regarding infection, certainly this is one of the worry when we using the CD7 CAR T therapy. However, we do not see any increased rate of infection from the day of infusing of the CAR T and until right before their transplantation, because after transplantation it's kind of hard to assess whether due to allotransplantation or not. However, during the period before transplantation, and we do not clearly see any evidence. And actually, I just presented a data for our treatment for TALL patient. In that group of 14 patients, we see one patient have the reactivation of the CMV. However, that patient was after the allotransplantation, after allotransplantation patient before CAR T therapy, so had a reactivation of CMV. But other than that, there's no clear increased infection.
So we have... Sorry.
Regarding the second question.
Oh, okay. Sorry.
Remind me again, the second question is...
So the second question was the response of the extramedullary bulky disease assessed using CT or PET scan?
That's all assessed by PET CT scan. Actually, the one patient on day 28 achieved a partial remission. That patient repeated a PET CT scan in 2 months and showed a further improvement of his mediastinal mass. We actually wanted him to wait longer, do not go for allotransplantation. However, that patient was very anxious and insisted to pursue allotransplantation, so we could not follow up longer in that respect. But anyway, all our patients were assessed by PET CT scan before and after.
Thank you.
So we have a question on site.
Thank you. Ira Braunschweig, Montefiore Einstein. Congratulations, Dr. Liu. Question about immune reconstitution after this therapy. There was one patient, I think in this study, and a couple in the ALL study that did not go on to allotransplant, where their lymphocytes monitored.
Yes, we actually closely monitored their lymphocytes. For example, they are absolutely T cell, they are NK cell, they are B cell, and throughout the whole course, and certainly also after the allotransplantation. And we see a relatively constant T cell and NK cell level. However, right after the transplantation, certainly they are dropped. And then after that, after a short drop, they are returned and reconstitute after the allotransplantation. So that's what we're seeing for the whole course. And basically we are happy about that.
Apologies, we have to move on to the next session for time's sake. Thank you, Dr. Liu, again for this great presentation. And
Thank you.
next one will be given by Dr. Matthew Frigault from Mass Gen Hospital, Boston.